In the United States, health outcomes are not evenly distributed. Differences in life expectancy, chronic disease, and access to care vary across communities, across geography, and across time. To understand today's health gaps, it helps to look at how we got here. American medicine developed with a broader social and legal environment that included slavery and segregation. During the 19th century, enslaved black Americans were often subjected to medical treatment and experimentation without consent or legal protections that were afforded to others. These practices shaped early medical knowledge while excluding the people most affected from the decision-making and protection. After emancipation, segregation continued within hospitals, medical schools, and professional organizations. Opportunities for medical education and professional advancement were limited for many black physicians. As a result, black doctors formed parallel institutions to provide care, professional support, and training. These institutions filled critical gaps in access, especially in communities that were otherwise underserved. These early patterns influenced not just who practiced medicine, but where care was available and which communities were prioritized. Public policy and outcry played a central role in shaping access to healthcare services. Housing policy, including redlining, influenced where hospitals were built. Labor laws affected who qualified for employer-based insurance, and insurance design and eligibility rules shaped which populations could access consistent care. In many cases, these policies had uneven effects across communities, even when they were designed with health outcomes in mind. At the same time, policy changes also show how access can improve. When hospital participation in Medicare became tied to non-discrimination requirements, many more facilities were constructed and integrated their services, expanding access to care. These changes demonstrate an important public health principle. Health outcomes are strongly influenced by policy decisions and how those decisions are implemented. Today, differences in health outcomes still remain. Research shows that variations still exist in pain management, maternal health outcomes, chronic disease prevalence, and treatment experiences across racial and ethnic groups. These differences remain even after accounting for factors like income, education, and insurance status. Modern healthcare systems rely on data, clinical guidelines, and technologies shaped by historical trends. Without careful evaluation, these tools can unintentionally reinforce existing gaps in our access or outcomes. Understanding how current practices intersect with past decisions help explain why disparities continue and why addressing them requires system-level attention. History provides context for the future. Evidence suggests that data-driven policy, community-based care models, and a representative workforce can improve outcomes across populations, strengthening trust, improving access, and using data responsibly are practical steps toward better health outcomes. Efforts to strengthen the future are not about assigning blame, but recognizing how history still shapes health today.